I have the distinct pleasure of introducing Dr. Pamela Stanley. Dr. Stanley, biography is in your booklet, and I would just like to call attention to a couple of aspects. Dr. Stanley, she's been working with universities for the last 10 years and is now working with Dr. O'Rourke and her team regarding role identity and influencing that integration into nursing curricula. She has overseen implementation of several projects, process improvement, EMR, which was like, when we first started EMRs, software integration, and new graduate programs. Her passion is building nursing education and curriculum to support nursing students and faculty at all levels. She has been developing community partnerships where nursing students can complete clinical hours, which is a tremendous challenge all of us face. And she has served as a coach and mentor in teaching and embedding Dr. O'Rourke's role-driven practice theory in hospitals and within academic settings. Please help me welcome Dr. Pamela Stanley.
On. All right. All righty. So I'm kind of going to go along with what Dr. O'Rourke and Dr. Long started with, which is the history. And so we're going to go back to my childhood, where I had the privilege of growing up as the only kind of white person in the neighborhood. My community, it was in East Oakland. It was Hispanic and African American. And my family was poor. And I didn't realize what a privilege and a gift that was until many years later. It really allowed me to see the world differently. To add to that, I have difficulty learning. And when I was about 9, 10 years old, my elementary teacher told my parents they should waste no money on me on college. I could never be more than a secretary, to which I decided I was going to be a nurse and get a doctoral degree. And this was in the 70s. I'm not really sure the doctoral degree actually even existed yet. I don't even know how I knew that was a concept back then. So go forward, I graduate high school, I go straight into an associate degree nursing program, and after the first year, during my second year, I failed. And I had to return and regroup and figure out how to study and learn in a whole different fashion. That was my next gift. I then enter into the hospital system. I'm a new grad. I move through my career, and then I run into Dr. Maria O'Rourke in the early 2000s. And I always knew, like, I had these concepts of why can't we like terminate people for certain behaviors that were like unethical or what, but I didn't have the words to the song. So she came to our hospital, spent 2 years with us really integrating role clarity. And really we changed all of our policies, our procedures, our job descriptions. And so that was a revolutionary experience that changed my life and my trajectory and my career. So fast forward again, I got swept into academia. I never had a planned ticket for that career, but ended up all of a sudden I was teaching. Joined that, the college I was working at was going to start an undergrad nursing program. And I got voluntold that I was going to build the curriculum and design this program. Oh yeah, and I needed a theorist. I had no clue what I was doing. My next gift, they couldn't find anyone to come to this kind of floundering college to do this, so I decided to integrate Dr. Maria O'Rourke's work in the curriculum, haphazardly at best. We fast forward, and first year out, we have 100% on our NCLEX scores, but that's not where the story was. We had just closed down an LVN program because they had a pass rate of 40%. And the word on the street was, don't take their students because they're horrible, the ones that are getting through. This was a brand new program, and we started getting phone calls from Stanford and whatnot, what's different? Your students are different. So the pandemic hits, and I have to step in and actually do clinicals. And I noticed a few things. Number one, the nurses on the unit wanted to know when our students were graduating because they wanted to hire them. These students, this was the first time they'd been in the hospital, they were not anywhere near graduating. They could articulate their role. I had accidentally stumbled into something totally as a fluke. So we started, working down the road. We're doing all this stuff. All of a sudden, the BRN tells us, we're going to come do a site visit in 90 days. Now, most people prepare for BRN to come for your visit for 18 months to 2 years. We got 90 days notice. But here was the thing. CCNE was coming. The BRN was coming. We were already following the rules. We were already prepared for Joint Commission. So we got flying colors, no dings, no nothing. But that wasn't the story. The story was when the BRN asked the students what they knew about their practice, they took them to the BRN site. They took them to the scope of practice. They took them to the ANA. They said they'd never seen anyone do that. We were getting ready to start to publish, and the school kind of had a little problem called bankruptcy. So fast forward, there's another job that came up, and I applied, and I said, Maria, I had never told you what we had done and the outcomes we were seeing. If I get this job, will you come work with us so we can put this on steroids? And thus began our actual journey where we started to launch this BSN undergrad program. So what we're going to do today is I'm going to talk about the launch, the grounding of the theoretical framework, how we built this around the curriculum in motion, talk about the fact we're actually starting to research these students, so we've got an IRB approval, and we're embedding all of her work and all of the standards around our practice within the curriculum. So St. Mary's College, to have some context, is a LaSallian school. We opened the program in the fall of 2025. So our data right now is very subjective. We don't have all of the other data. We don't have graduates yet. We don't have any of our data from the research that we started. We have 5 consecutive semesters, it's 64 units. We will be accepting 100 students a year, 50 in the fall, 50 in the spring. We started with small cohorts of 18 and 22 because you never get it right the first time, so let's have a small group. It's easier to fix your mistakes and kind of build up. The foundation, though, that we built everything around was do no harm. And the do no harm is not just to the patients, it's actually to the students as well. So consciously what we recognized was launching the new program required intentional leadership to shape the academic culture. We didn't have, culture dies a hard death. And so the reason we have bullying still in healthcare, it's been embedded in the culture. When I was in nursing school, when the dinosaurs roamed, they talked about bullying. I think I've been a nurse, it's a long time, so early 80s, mid-80s. So when you look at that, it's still that alive and well. So we're repeating and sustaining the culture. So we had an opportunity to try to establish a different culture in academia. Because you do hear, our students have to meet these high metrics to get in. Why don't they get through the program? What is it that we're not doing to support our students? So one of the first things is in doing the professional role identity formation theory, we have to make sure our faculty that we hire understand it to even model it. This is where my lessons were learned, because sometimes you can have an idea that you understand the world, but you don't really understand it. The learning curve to get our faculty to really be able to articulate and do this, we started before we had students. Making sure, they understood what the difference between a professional was, and then understanding how to apply it to nursing, understanding all this, how the scope, the standards, everything connected. And the common thing we would hear from the faculty is, well, this is how I was taught. Well, that's part of the problem. Or they would go back to, but they need to know how to do the task. Well, I can teach a 5-year-old how to put a Foley in. It might not be ethical, but I could. but they don't know why they're doing it. They don't have all the principles behind it. There's more to the task. It's really understanding the role and whatnot. So we really had to take the faculty on this journey where their values were clarified, where they could have that self-other interaction. Dr. O'Rourke has been living with us, and sometimes I think she actually had black hair when she started with us, but it's been a rough road. And we really now have where that role transition and adoption has happened with the key faculty that are leading. And now as we're bringing in this next group that's joining us, they're already recognizing this is different. We're interviewing different, and we're constantly refining what we're doing to embrace the whole role even more deeply. This is the model of the professional role. There's 3 key components you'll see in the center: leader, decision maker, transfer of knowledge, practitioner, and scientist. Everything we do is built around this. You'll notice the do no harm, the patient first, professional standards and ethics, the ANA social policy, science, all surrounds this. Our whole entire program is built around this, and this is embedded in our model and everything we do, every policy, every procedure. So the next thing was really getting our faculty to understand what it meant to be a leader, a scientist, a practitioner, and practitioner really refers to what it is you do. So in the case of me, my area of practice is both in education, because I work in the academic setting, but I also still do clinical, so it's still that piece as well. So practitioner isn't just the laying on the hands in the clinical setting. It has to do where you are actually implementing the role of the nurse. And then knowledge transfer. So first was letting them to understand that, but then they had to understand in the context and almost grieve the fact that in their current roles, they may not have been incorporating all of these or been able to explain them. There was a lot of pain. The faculty, these were really good nurses. They're people I had worked with for years, exceptional with students. They were grieving the fact that they hadn't been able to articulate their role in their career. And they had to let go of that and almost go through a forgiveness process. I didn't have that on my bingo card. So that took us a long time, and so we're recognizing as we're bringing people in, we're having to orient them differently and doing small conversations. Our interviews are different. We start off with them understanding the principle of do no harm to students has become key to our faculty to understand, no, you can't just treat the student that way. You know, if the student fails, what is all the stuff we did? And someone can fail and you can leave them intact. I actually fired someone in my career and I got a thank you note. And people are like, does she know she's not coming to work Monday? I didn't have to destroy her in the fact that she was going to lose her license if she stayed in the environment she was in. So we actually then work with the faculty to have them understand that they're a leader and decision maker in the classroom, in the clinical setting, that when you go to a hospital, yes, we're guests in the hospital, but you have to own that role. You are still a nurse when you walk through the doors. You're responsible for the students. You're responsible for those behaviors. You're responsible for those interventions. The scientists, making sure the faculty, whenever they present well, this isn't how I was taught. You know, I'll say, well, you know, you might not have been in a car seat either when you were a baby, but we now have car seats. You know, as the evidence changes, we change our practice. And so they're expected to keep up on the clinical piece, but also to start to embrace, there's a whole philosophy and scientific data around how people learn and how to teach. Our faculty have not necessarily gone to school to be educators. So there is a role in teaching them how to teach. And then having them really understanding what it means to apply as a practitioner in both the clinical as well as the theory classes, and not having the gap. So not seeing the clinical faculty separate from the theory, that we're all responsible for what happens in the clinical site. So we're responsible and own the knowledge transfer. So one of the big changes for the faculty that have practiced elsewhere, When students take every practice test, we use ATI, we do everything in the classroom under monitoring. So we get data to what the students still don't understand. And we have to respond to that and own. I may have stood up here 20 times and talked about evidence-based practice. They still didn't get it on the test. I have an ownership in the transfer of knowledge. And how do we as a group reorganize so the students actually learn that? So that's where it really became, because we're using evidence-based practice, our evidence becomes, what are the testings? What are we seeing in clinical? What are we this? How do we change in order for them to be successful? So we identify those gaps. We work with all the faculty. Hey, the students don't understand still what evidence-based practice is. Can everyone this week bring an article in that ties to what you're teaching and talk about how that evidence was created? Or show how something has come to light that isn't evidence-based, but where, you know, and of course vaccines always makes the way in there. Where did it come from? How did it get there? And then we also look at anything, if they're not getting something in theory, students weren't understanding aseptic technique, let's take it into the clinical and let's do a whole simulation experience where everything's around sterile technique. And let's bring in everything from videos to patient stories to nursing stories to let's have them set up sterile fields and really understand that philosophy. And the test scores went up. So we're constantly doing this, and we're looking at the outcome measures. The other piece we're looking at when we're testing students, we don't have faculty fail students as an individual, meaning I'm not the one alone that fails you. If you're failing the course, you go to the professional practice committee, which is all built around the role clarity and all of those components, and we look at the student, we look at their test score, we look at this. Are we going to fail them here in this moment in time and have them repeat? Or are we going to put them on a developmental plan, move them forward this semester, and see if we can have them on track and continue through the program? And so those are the components. So the last semester we moved 4 students forward that technically didn't have the level 2 on our ATI exam to move forward. Out of those 4, 3 of them are doing very well and should progress through the program. The other one, there does come a point you can do everything, but the other person has to be wanting to participate. You can't fix that behavior. So we're not trying to fix our students' behaviors. We're trying to support the students and how can we match them up that will help them learn and teach, you know, in that manner. So those are the pieces that we have built in. We're actually are studying our students right now. Our second cohort signed consent, and we're doing we administer this proof behavior assessment, which is from Dr. Maria Rourke. We're then going to assess them again after level 2 classes and at the end of the program. In addition to that, we've built the behaviors into our simulation, our skills, and our clinical evaluations. And we're already seeing these things play out, and I'll share a story shortly on that. So these are kind of the things we're doing in regards to simulation. We're looking to make sure that they understand decision authority scenarios, clinical reasoning, knowledge transfer events, and professional role debriefs. Everything links back to the actual model, and we do the same thing in the clinicals. So we have built all of our tools. Everything is mapped back to what are the observable behaviors. Everything is mapped to our mission, our vision. We just discovered that our evaluations didn't get the 100%. We only have one semester that we've got evaluations from, but we didn't have 100%. So I was like, all right, well, we need to redo this process and everything. And in redoing the process, I recognized the questions were kind of stupid. We were, I'm just gonna, I don't have a better word for that. Nothing on there was having the student evaluate the course for the professional aspects or evaluate the faculty for did they demonstrate these. So we just created a whole new tool that we're planning to launch for the end of this semester when we do the evaluations. So now that the students will recognize and see, oh, now I'm evaluating the classroom based on all of this that we're talking about with the science and the evidence and this, and the faculty are now we're evaluating them, that they actually discuss these professional roles and that they helped us grow. So we're constantly closing and refining all of our mapping to make sure that we are capturing all of this. The hardest part actually so far has been the faculty development. It hasn't been the students, and I think the reason for that, the students come in, they weren't a nurse before, so it's all new knowledge. I'm not trying to break old habits. That was my lesson for 2025. So those are kind of the roles that we had before, and we really wanted to move the faculty over to clinical reasoning. We wanted them to be a role model, a coach. We were really looking for them to understand they were a decision maker and a leader. I thought this was going to be the easy part. So this is an example of a faculty member, well-intentioned. We had an opportunity to actually take students into the ER, and you know, placements are hard, so you give me a spot, I'll figure it out. And so on the surface, this looks like this is a great idea. She's going to post this up. It's a live experience in the emergency room. Demonstrates situational awareness during fast-paced care activities in the ER. Not really sure what that means. And you'll notice, apply therapeutic communication and empathy with patients and families in the ER. Perform basic skills. So again, it's very task-based. And so in working with the faculty, we redid this and talked about the fact this is really about an immersive student and a role-driven practice within a dynamic ED setting, providing a live learning experience where students begin to recognize the distinct professional roles of the registered nurse. There's so much they can learn by having to talk about what they saw. This experience supports the development of professional identity, emphasizing clinical reasoning, communication, accountability, and safety as foundational elements of nursing practice. Through guided observation and supervised participation, students connect theoretical knowledge with professional role behaviors that uphold patient safety, advocacy, and collaborative care. And then these became the objectives. Demonstrate professional role awareness by articulating the RN scope of accountability, authority, and decision-making within the interprofessional ED team. What did they see? Apply clinical reasoning to identify patient priorities using the ABCs, the Emergency Severity Index, and observe nursing judgment. Perform nursing care safely under supervision, demonstrating the RN's ethical and evidence-based commitment to do no harm. Because the reality is, taking vital signs is a task. But if they take it on an arm where there's a shunt, they did the vital signs correctly, but the whole rest of it fell apart. Exhibit professional role-driven communication through therapeutic engagement with patients, families, and colleagues using SBAC and TEACH-BAC methods. So really calling out what is the communication we're looking for. And reflect on role-driven practice, identifying how nurses integrate knowledge, advocacy, and leadership behaviors in a fast-paced, high-acuity environment. So it changed what the students were doing, and then it changed post-conference. Now we've added that the students during their day, when the nurse they're assigned to goes on break, they have to go on break. When the nurse goes to lunch, they also go to lunch. In addition, they have a lunch with the faculty, kind of gets them off the floor where they're not supposed to. They just go all together, the faculty eats separately, but they can have some downtime. Those breaks, they are given actual tools that they have to look at that are based around the professional role for what they have seen, whether it's, when did you see someone using the scope of practice in making a decision? There's all these things we lay out. So when they come to debriefing, the conversations are different. So the faculty onboarding, I'm not going to spend too much time on this. I think you get the slides, which is why I kind of included it. It really has a phase 1, a phase 2, and a phase 3. We are thinking onboarding to have faculty completing up and independently practicing is going to be a year. So they are assigned mentors to really be with them, not just for the teaching part, but to actually have them get comfortable with the professional role elements. And they're actually handed Section 2725, and they're told to read it before they show up. We talk about this in orientation, but we make sure they actually have these items prior to meeting us the first day as part of their orientation. So it changes the tone. I don't ask if they've ever read their Practice Act before because I've decided I don't want to know for personal reasons. So the culture change is really what we're doing. So that's how I was taught, was the big thing. So we have been looking at moving the whole faculty into really understanding that why we are focused on theory, patients need skills. Without having the theory ground you, we're creating the same thing we're complaining about in the hospital. We just have task-based nurses. Well, what did you expect? That's what we taught them. We didn't teach them a whole encompassing role, and oh yeah, there's a Foley I have to put in. The Foley part is the simple piece. The challenge is the whole other piece. We had to really work with the staff to understand what their role was in academia, and it really was being accountable, the obligation, they're having to step forward, and they come from an environment where they're used to blame. Even you'll hear other faculty, well, my raise is tied to my evaluation. Okay, if the students complain, okay, well, how do we make this more meaningful? So the Professional Practice Committee allows us a place to say, everything we look at is in relationship to our system. So if your class didn't go off well, it's not you, it's us as a team. How do we change this and learn from this and improve on it for the next semester? So it really is removing the blame. When a student fails, we all fail. So what do? Can we mentor the student? Can we move them forward? It's really changing a culture. And at first, when people come in, they're a little bit nervous, like, where's the surprise hanging around the corner? Because it really is a different way of doing things. And, people will say, well, what about our, NCLEX? We were able to do the same things at HNU, and we had a 100% pass rate. So the NCLEX scores will follow this because the professional role is tied to NCLEX. It's just, we're actually labeling it differently. So we're starting with values, not the rules. What is it we value? We're honoring their clinical experience. That's why they're there. We're not trying to tell them they've been horrible nurses. We want to honor that. And I share my own stories with, when I had worked with Maria, I had a lot of epiphanies, and it was a painful process. And, recognizing that it is a growth that they're doing. Showing them the evidence, they're constantly getting inundated with articles on Maria's work, and then really letting them see the behaviors that the students are demonstrating. And the faculty are seeing, and this is subjective for me. So we launched our first cohort in 2025 in the fall. Okay, so we see certain behaviors with that group. We launched the second group in the spring. Well, because we're evolving and changing, we've changed some of the things we do. I teach the professional role class, one of the first classes they take. I changed how I taught because I recognize things. Everyone is recognizing our second group is performing better with identifying these role pieces than the first group. And an example is we had a nursing student who took vital signs that were out of range in a clinical setting, and it was the senior group, and she told the CNA. The faculty wasn't told, the nurse wasn't told. And she was very upset that we have incident reports, just like here in the hospital. There's an incident report that we generate because you didn't follow this. Her whole thing was, well, the faculty member didn't tell me I was supposed to do that, to which you had a whole class on the scope of practice. So why do you think it's okay to give the CNA? Is that within her scope? And it was this whole conversation where we went back to it. Meanwhile, I took the example to the juniors I was teaching, and we talked about vital signs, and I said, can you give that report if they're out of range to the CNA? To which the students immediately, now remember, I'm teaching differently. The students said, well, no. And I said, well, why? Well, it's not part of their scope of practice. I have to tell the RN, and they didn't get the faculty piece, but they did get the RN because it's under their scope of practice. So we're recognizing that we are changing when we identify it didn't quite click yet. So we have to go back and then clean up the first group to make sure they have the same data. But those are the things that we're doing, and we are celebrating our small wins. This is, and I've left this is just kind of give you some examples of how to twist the whole, these are actually real things that people said. My clinical experience is what makes me a good teacher. I don't need a framework. That was a real big one. Yeah, we're there now. So these are just examples of how to change the thought process of the faculty is so important. It's not just about the students. Everything that we're doing already naturally aligns with AAC Essentials. It aligns to QSIN. 15 to 21% is management of care. That's all under professional role obligations, priority setting, delegation, accountability, and advocacy. We are not doing something extra. We're just grounding everything in a clear, articulated way. So then you wonder, well, has it made any difference? So come to post-conference. I was the clinical person there, and we're doing debriefing. And I said, so tell me a time that you took accountability today. And someone said, I want to share a story with you. She goes, so we think it's a doctor that came out and said, the patient spilled all their food, you need to go clean it up. I'm like, yeah, it probably was. So I said, what'd you do? She goes, well, I realized that was within my scope of a student nurse. I could go in and clean that up. And so I went ahead and took one of my colleagues with me so we could go clean it up. But then we got into the room and we realized the patient had soiled herself. And we understood that it was within our scope, we could clean the patient up. We also understood the patient remaining in there, it was a chance for skin breakdown, infection control, and a dignity issue. I wanted to cry right there. Later on in that same debriefing, someone else they were having fun with it. And then I transferred knowledge to the physician. They're getting it. It was like, they're understanding how to talk different and see different. The other thing is when I went out on the floor, never were the students not doing something because they actually understood they had a role. They understood they had a scope. They understood it wasn't about being there to give the medication. They understood it was about so much more than just the task, so they were behaving differently. The nurses noticed that they were actually behaving differently. The nurses actually thanked the students at the end of the shift. I almost collapsed on the floor and had a heart attack. I could feel that, I'm like, nurses thanking the students because their shift was made better because they were there. That was because when they saw like, oh, your patient is calling because they want some water. I see that, and this is the thing, they would look. I see that the patient can have fluids and they're not restricted. Are you okay if I take them in? So the staff are seeing, not only are they offering to do the task, they're also letting me know, oh, I looked at the chart and it says that they're not restricted. So they're doing that extra step of care, not just taking in the water. So the role clarity has been embedded across the students, across the faculty. We're changing how we do the clinical debriefings. We're constantly revising. In May, we have a 3-day off-site in between semesters. We're bringing everyone together to review policies, procedures, our student handbook, is anything not centered role clarity? Do we need something different? And we're doing training. Poor Dr. O'Rourke's coming down again to be tortured to play with us. And then clinical partners, as we have some partners that we're very fortunate also have her work embedded. So it's allowed us to start to do things differently in the clinical sites there, and we're looking at some joint work in some studies and some research. So the RN's feedback, and this is all subjective right now, is they really appreciate the students there. I also had a hospital leader who actually said that our students are performing better than any of the other nursing programs that are coming there. I won't say who it is because I don't, but that felt good. And they're recognizing they're actually part of the team. And our students feel when they're there, they're actually part of the team. They're not just coming in there as students to do a Foley or do an injection. And then I'm seeing that they're engaging. They're not just waiting for the opportunity to do the glorified work of the shot. They see the value in cleaning the patient up. They see it as an opportunity to learn. So it's really changing the whole way people are participating in the clinical setting. So what does and our big thing also, we have decided nursing students are never competent, and we will never use that word. Our nursing students need to be practice ready and practice safe. And practice ready for me is they understand their role and they understand not to just do stuff. You know, that they'll stop and say, I don't understand how to do this. So we aren't looking for competency. We're looking that they're practice ready and practice safe to do that transition over. So we're looking that they understand accountability is not as compliance, but it's a professional obligation. They don't have a choice. If they're holding the license, they are accountable. They understand the theory that is grounded around the science, so they really leave us knowing what their role is. They know the ANA standards, the scope of practice, the code of ethics. They have all of those pieces. They can explain the model of the professional role nursing to the next generation. We want them to leave, and as they're out there, that they actually can explain this and what it means to be a professional. That they, if someone says something, they can say, well, we can't do that. That's not part of our scope and standards, or that's not part of the Practice Act. They can actually have those words to use to advocate for themselves and others. We're looking for them to understand that they have decision-making authority. We also don't use the nursing process. We use a decision-making model that comes directly out of Dr. O'Rourke's work, because you can process forever and never make a decision. And the stability of the patient, which is a key component, really changes your decisions. So we use the 9-step decision-making model, which is one of the training things that we really had a hard time with faculty understanding. No, we are using this model. And we want them to be empowered leaders. We want them to really understand where their role is and be able to speak to it. And then adaptive practitioners. They are definitely going to be going out into an environment where that is going to be a key piece. So the implications for nursing education, theory really needs to be an infrastructure. I actually was recently with some colleagues and something came up and I said, so what is the theory that your school is grounded to? They don't have a theory. Well, if you don't have a theory that somehow tells you what you're all doing together, how is your curriculum like connected? How are they graduating with a cohesive something? So I thought that was interesting. Faculty are really the leveraging point, which I really missed and didn't get until I was deep in the weeds. We need to invest in the faculty with ongoing training and lots of mentoring and lots of one-on-ones. And that's really where, if you don't get that built, they can't model what they don't understand. And I don't know why, but I didn't really understand how big that gap was from people coming, which to me is kind of not very smart right now. Simulation as a professional role identity laboratory. Simulation just isn't about doing the skill. We are having a chance to see the behaviors that they demonstrate and actually acknowledge, hey, I saw when you were in the simulation that you used that decision-making authority and you did X, or you brought in evidence-based practice, you were being the scientist. So calling out those positives and letting them see how they're using it, and then helping the student refine, like, hey, you could have worked a little bit on the transfer of knowledge by X, Y, Z, whatever it is, but really going back to the model so we're always constantly grinding them back. And it's really, a culture change requires structure. If we don't put the structure in place as we're starting this new program, the culture that's going to emerge is the culture that we already don't like in the hospital, the bullying. Faculty actually bully students. It's alive and well. And interestingly enough, students have started bullying faculty. So I've made it very clear to the students when I teach, well, we say that, do no harm to patients, do no harm to students. We also don't allow harm to the faculty. And we won't tolerate bullying any direction. So those are important pieces in establishing the culture. Culture dies a hard death. Building a culture from the ground up is very challenging because you do have behaviors that people try to bring in and move into place. So we did have a faculty member that didn't quite fit with this cultural piece, and they're no longer with us because we cannot go against what our core is, which is to do no harm. And our students are considered protected. It doesn't mean we don't handle situations, but it means anything that we need to deal with goes to the professional practice committee. The professional practice committee is run by 2 of the assistant directors. They chair it, and different faculty rotate in to hear and analyze the case and make those judgments. So not one faculty member has the power to fail someone. And so that leverages things in a different fashion. And then really it serves the underserved through the role clarity and ethics. Coming from as a poor child, when you come in to nursing, you do not have the same skill sets. You didn't have the same academic. Our goal, you made it into the program. Let's help you and figure out where your gaps are so we can make you through. And that's the equity that we're grounded to. And I think I made it under time. Yes! I think it's, one last slide, yes. So, who one is, what one does. When professional role identity is clear in faculty and in students, academic culture becomes accelerant for practice transformation. So PRIF is providing the why, the standards are the what. Curriculum in motion requires intentional theory-grounded structure. Faculty role clarity is the most powerful cultural change lever, and simulation is where identity is formed, tested, and measured. And that is it.